channel. If you have a question, please be mindful of the time. Make your question brief and place them in the Q&A section of your drop-down menu. As there will be one or two similar questions, we will consolidate them to get the best and most effective answer for you. The town hall will be presented every 2 weeks with an expert in the medical or healthcare field. Additionally, we ask you to join us for our annual estate planning webinar, hosted by our resident law expert, Janice L. Mathis, Esquire. She will have a guest or two that will make this webinar enlightening. The flyer invitation has been sent via email and will be resent. You can also find it on social media, Facebook, LinkedIn, and Instagram. Thank you, and I will now turn it over to our co-chair of the NCNW Health Equity Committee, Ms. Shara Denton.
Good evening. I'm Shara Denton, Chair of the Health Equity Committee for the National Council of Negro Women, and I want to welcome you all to our Influenza Town Hall. Don't let flu get the better of you. In this webinar, you will learn who is the most at risk, how effective are the flu shots, and are the vaccines safe. In a little while, I will introduce our wonderful speaker for the evening. And in the meantime, I would like to also welcome our newly elected chair of the National Council of Negro Women, A. Lois Keys. At this time, I will introduce Willis Williams, who will talk about the next steps in the program.
Good evening. I bring you greetings from the state of South Carolina and the members of the South Carolina State Mechanism of NCNW. We have an opportunity through webinars like this to educate ourselves and the public about issues that matter. We are continuing to learn that something as common as the flu can be deadly serious, especially to seniors and pregnant women. Tonight, our special guest and featured speaker has a military and homeland security background and will provide us with a unique perspective. We are glad that you chose to join us tonight. On behalf of Dr. A. Lois Keith, Chair of the Board, and NCNW National President, Reverend Siobhan Bradley, I welcome you. I encourage you to share NCNW with your friends and family. If you're not a member of NCNW, please consider joining. General membership is only $50 per year. Membership is how we're able to present high quality information without charging a fee. Shara Denton, Chair of the Health Equity Committee, will now come again with the presentation of the speaker.
Thank you so much for your time and taking that poll. At this time, I would like to introduce our speaker, Dr. Robin Hunter Buskey, who is the Clinical Services Support Unit Chief for the Department of Homeland Security, Immigration and Customs Enforcement and Renewal Operations, ICE Health Service Corps. She is a senior physician assistant with the U.S. Public Health Service. She served nearly 18 years as a management official and clinician with the Federal Bureau of Prisons. With more than 40 years of clinical experience in various primary care settings as a PA and physical therapist, she continues to serve target populations and improving access to comprehensive health care. Dr. Hunter Buskey earned 2 Bachelor of Science degrees from Stony Brook University, a master's degree from the University of Nebraska, and a Doctor of Health Science degree from A.T. Still University. In 2009, she obtained certification as a correctional health professional from the National Commission of Correctional Health Care. She is also a certified diabetic educator and quality health professional. Dr. Hunter Buskey serves as a mentor, author, and educator. She is a life member of Zeta Phi Beta Sorority Incorporated, and she is the chair for the National Panhellenic Council of Presidents, COVID-19 Task Force, serving since May 2020. At this time, please welcome our speaker, Dr. Robin Hunter Buskey.
Trying to come off mute. Thank you, ma'am. Thank you, Ms. Denton, for that wonderful introduction. And I will say that that last question, or the next to last question about learning something new, I certainly learned something new already and appreciate the audience response to those various questions. And we'll try to weave them into the remarks I have for you this evening. Don't let the flu get the better of you. Good health wins. Good health always wins. For the audience, I'm going to turn off my camera to save on bandwidth, and I'm going to ask for my slides to come up. And as that's happening, I want to thank the NCNW for this privilege. I'm pleased to share information about influenza illness, prevention, and the things we can do to help improve the health of our community. Let's see how I can do this. So we can go to the next slide, please. Can you hear me? Testing, testing. Next slide, please. There we go. Okay, next slide, please. Well, I'll keep talking and perhaps the slides will catch up. So for the record, I must state that the opinions expressed in this presentation are those of mine, and they do not necessarily represent the opinions of the Immigration and Customs Enforcement, Health Service Corps, or the United States Public Health Service. At the end of this presentation, you'll be able to describe influenza infection, symptoms, and the public health impact. You'll be able to understand influenza prevention, as well as discuss ways that community leaders can promote healthy outcomes. Next slide, please. We'll start by looking at influenza disease burden in the United States by season. The next slide will illustrate some pyramids, and what you'll see there are 3 categories, one being illnesses, the second being hospitalizations, and the third is deaths. And this is looking at 10 years, so the last decade. What I want to draw to your attention is the relationship between the gold and red for each of the flu season pyramids. You'll see that they vary in size and the dimensions there. What those are influenced by are the types of influenza viruses for those particular seasons, the target population, the numbers vaccinated, and those with high risk, such as the elderly, children under the age of 5, and individuals with comorbidities, among other factors. If you look at the far right, the past 2 years dipped due to the overwhelming COVID-19 virus. We are on track to see a very serious influenza season for 22-23, perhaps not as severe as that big spike in 2017-2018. Next slide, please. The next pyramid we'll look at is just looking at the estimated range of the annual burden of flu in the United States over the past decade. The burden of influenza disease in the United States can vary widely and is determined by a number of factors, including the characteristics of the types of viruses, the timing of the season, as well as how well the vaccine is working to protect those against illness, as well as how many people got vaccinated. We could see even in our sample tonight, we don't achieve 100% vaccination. 80% is good, but it's not good enough. While the impact of flu varies, it places a substantial burden on the health of the people in the United States each year. The CDC estimates that from 2010 to 2020, influenza has resulted in between 9 million and 41 million illnesses, between 140,000 and 710,000 hospitalizations, and between 12,000 and 52,000 deaths annually. So why do we see that variation? Part of the reason is that many people do not seek medical assistance when they have the flu. They treat themselves at home. But in the 2022-23 flu season, the one we're in now, to date, we have about 4.4 million illnesses, 38,000 hospitalizations, and 21,000 deaths. And unfortunately, that death number includes children. Next slide, please. I put in a picture of the maps to give you some perspective about where flu impacts us in the United States. So this first map is showing December 2022. You see a lot of deep colors, those reds, dark oranges. That's showing you very high. And where you see purple, those are the highest numbers of activity level for flu. So this is a snapshot from just mid-December. Now, if you would go to the next slide, please, you'll see the color variations change. What's promising is that the colors lighten up. We've hit the peak of the flu season and it's plateaued and actually starting to decline. The challenge is that we still have flu. It is not over yet. Our season goes until about April, sometimes into early May. So although the number has peaked, we still have a long tail. And I have a picture to show you that later. Next slide, please. So now I want to define influenza for you. The flu is a viral respiratory infection of the nose, throat, and lungs, causing fever, severe ache, and phlegm. It can cause mild to severe illness and can lead to death. People at the highest risk of developing flu complications, and I'm just going to tell you these types of people. Some are under the age of 2, those older than 65, residents of nursing homes or other long-term care facilities, people who are pregnant or plan to be pregnant during the flu season, those with weakened immune systems, American Indians, Alaska Natives, those with chronic illnesses, and we saw some on your questions, asthma, heart disease, kidney disease, liver disease, and diabetes, and people who are morbidly obese, and that is having a BMI of more than 40. Symptoms include all of these or some of these: fever or feeling feverish with chills, dry cough, sore throat, runny or stuffy nose, muscle or body aches, headaches, fatigue, and some people have GI symptoms such as vomiting or diarrhea, although that's much more common in children. It is important to state that not everyone with the flu will have fever. The flu comes on very suddenly. And although you can have a cold and feel uncomfortable and miserable, you feel much worse when you have the flu. Some have difficulty breathing. They may have chest pain, dizziness, seizures, or other worsening of conditions that they have. That's when you really need to seek medical attention. Now, the flu is generally spread by tiny droplets, most noted when people cough or sneeze or talk. Now, how would you be able to distinguish the flu from COVID? If a person has COVID, it could take them a little longer to realize that they have an infection. We realize that, back in the early days of COVID, if you had a change in the sense of smell or you had a dry cough that wouldn't stop, those may be early symptoms related to COVID. Today, some of the symptoms could overlap between influenza and COVID, and there are many individuals who have both conditions at the same time. But in general, if you're exposed to someone with the flu, it can take 1 to 4 days before you start seeing symptoms. In COVID, it can take from 2 to 5 days, but it could take up to 2 weeks. And what we're learning with these emergent variants, that it could be less than that. It could be pretty quickly, within 36 hours from exposure to illness. Some individuals that develop COVID are contagious for longer periods of time. Thus, there are still recommendations for quarantine and isolation if you know you have COVID. There are also other viruses out there that are not flu and that are not COVID that are most noted during this season of the year. Nevertheless, whenever you have symptoms of not feeling well, you should contain yourself away from others. And if you have others that are sick, you should try not to be in their company for prolonged periods of time. Next slide, please. Now, the next slide is a little bit busy, so I'm going to walk you through it and help you understand what flu season looks like. Now, the flu season that we're in has already peaked. I showed you that on those maps. But what you're seeing here are different years of flu season. And what you'll notice is that there's a peak and then a very long tail, depicting the length of the flu season. So we name flu seasons for the duration of that season. It crosses from year to year. So if you would advance the slide, you'll see the arrow there pointing to the gold line, and that's showing you the flu during the actual pandemic, the COVID pandemic. If you click again, I want you to look at that red line, which is where we are today. So you see how brisk and fast the peak occurred for the 2022-2023 flu season, and it's already coming down. But you see the long tail. It's got some time. We're still in January. So we have until at least April, if not early May, before this flu season is over. There are significant complications with the flu. As I've said, it can worsen some of the conditions that you already have. However, the flu could result in death, and that is why it's so important for us to work on prevention. Next slide, please. So now I want to talk a little bit about immunity, because sometimes this contributes to why people don't want to take their flu shot. They're afraid of getting sick, and they may not really understand that the myth that we hear is, well, let me get the flu because then I'll be cured, or I won't have to worry about the shot, or things like that. So there is 4 different types of immunity that I've listed there for you. But in simple terms, immunity is the body's ability to stand up defense against infection. So when you have active immunity, that is actually the body creating its own antibodies, and it is in response to exposure to a particular infection or to a vaccine. Passive immunity is because it's given to you or passed on to you, such as when a mother is breastfeeding. Passive immunity does not last as long. It just gives you time. Natural immunity is similar to passive immunity, where you could have an infection or it can be given to you passively. Also, time limited. And then artificial immunity are antibodies that are generated specifically from vaccines or serums. So whatever type of immunity you get, when we have a known vaccine that can prevent or reduce the symptoms and sequelae related to a condition, that is always recommended over getting the condition, because we can't control what would happen to you if in fact you get sick. It is a safe way to promote community safety and good health, and it helps to minimize the worsening of underlying conditions and or death. Next slide, please. So what are the best ways to prevent serious influenza illness? Well, we've already spoken about the vaccine, but I will say that vaccines are not 100%. They don't prevent illness, but what they do is they reduce the complications. They can shorten the course of an illness should you contract it. To date, 171 million doses of flu vaccine have been distributed to the United States, mostly to pharmacies and doctors' offices. So I was glad to see that the majority of those of you who have been vaccinated, that's exactly where you got your vaccine from. Our bodies do need help. So the vaccines are a proven method to prevent illness and disease. They're strongly recommended. Now, I've listed there pneumococcal and Shingrix. You probably see some of the commercials for these vaccines because they can be given actually at any time of the year, but it's a good idea if you're going in to get one vaccine, why not see if there are others that you can get at the same time? And these are definitely given to individuals who could be at high risk, so it could be based on age or other reasons. But nevertheless, when you go in and talk about your flu vaccine, and probably soon an annual COVID vaccine, these are other vaccines that you don't have to take on an annual basis, but they have a course that are prescribed for you. Then there's the public health and personal mitigation. So I'm just going to talk about 3 specific areas. First, the public health. Traveling is increasing. So if you're sick, please don't travel. Travelers can be exposed to influenza in a variety of ways. Influenza is a worldwide condition. So when you go on trips like cruises, you're exposed to people from all over the world. So you want to be careful. You can only really police yourself. So if you're sick, please don't travel. The other thing is that when we look at our flu vaccine, the one for the Northern Hemisphere, it's very good because even though it's targeting the flu virus that we anticipate in the United States and the Northern continent, it also can help protect in other parts of the world. So we do very, very well with our flu vaccines. Then there's the personal mitigation. Recognize your symptoms. If you are sick, don't go to work. What happens is people will go out, travel, they'll be out and about, mixing with all different types of individuals. And you've all probably been in a store and stood on the line and watched someone with their child or someone else who's coughing all over the place, touching everything. Again, we're trying to help change behaviors. If you're sick, try to help that person stay in a contained area, keep the area clean, wash your hands. If you're handling their laundry or their tissues or their garbage, wash your hands. The hint there is wash your hands. The next thing is taking precautions. Now, we are becoming mask-like individuals. There's no more mandates. So it's up to you to decide if wearing a mask is going to help protect you in a certain environment or help others because you're in their environment. But at the end of the day, you want to make sure that you disinfect commonly used surfaces and wash your hands and stay home until you feel better. Feeling better includes not having fever for 24 hours if you've had to use Tylenol, ibuprofen, or some other medicine to lower fever. The last thing I'll mention are in-person meetings. I'm sure many of you who are connected this evening are involved in organizations that have been looking at how do we get back to our norm? How do we get back to the networking in person? Well, COVID-19 has certainly influenced how we gather. Meeting planners are adding requirements such as, have you been vaccinated? Using masks, washing your hands, ensuring there's adequate ventilation, symptom checks, testing access, contact tracing, among other things. So at the end of the day, for those of us who plan in-person meetings, we really need to look at local partnerships to have access, because if someone travels and intends to participate in a conference for 4 or 5 days, what happens when they get sick and they have to stay? What support can we offer each other? So these are things we're going to have to think about going forward, if not for today's meetings, but for future meetings. Next slide, please. So now, how are we doing with getting flu vaccines? Well, I do appreciate, again, the results of your poll, knowing that 80% of you have gotten a vaccine, and the majority are in the oldest age range, I'll say it that way, but that I was concerned to see some of the reasons why you didn't get flu shots for those of you who chose not to. So here, what I'm showing you, it's again a little bit busy, but let me walk you through the slide. So if you're on the left of this slide and you see that dark green on the top bar, that is overall for anyone who's an adult. You see the dark green shows it's just under 50% of individuals who got their flu shot thus far for this season. Okay, so this is just a snapshot in time. And you see there's the light green because those individuals said they think they're going to get a shot. And then you see the very light green that say, you know, they're still not sure. And then the pink who say clearly they're not going to get a shot. And below that, you see 3 bars where you see age groups. And it's good to see that those in the most senior age group, the 65 years and older, have really beat the bar, and they are getting their flu shots. On the right side, the bars are broken up by race and ethnicity. The top 2 bars are the ones I want you to look at. Those are the Black and brown people, the Blacks and the Hispanics, and they are well below that 50% of getting their flu shot, whereas the other and the white non-Hispanics are all at 50%. So this shows us we have work to do. Next slide, please. So a quick look at COVID. So what you're seeing in this next slide is some cumulative information about the COVID-19 vaccine by race and ethnicity. Another busy slide, but let me walk you through it. The first thing I want you to look at is the purple underline, which is the Native, Hawaiian, and other Pacific Islanders. If you look, there are 3 lines there, and it tells you who received their primary COVID vaccine, their booster vaccines. And you'll see that in that narrow group, 70% received at least 1 dose of a vaccine, 64% got their complete series, and then a small amount, 10%, got their booster. Now look at those 2 red circles. That is the Black and brown. Our Black, 8.1% have not received boosters. Have received boosters, and the Hispanics, 7.5%. But when you go up to the top, Blacks, 50% have received 1 vaccine for COVID, and 44% have received a complete series. And with the Hispanics, it's also well below what we would like to see for completing their vaccine series. So again, this tells us a little bit about who we need to target when we're focusing on our education efforts and helping to understand why these individuals that have chosen not to get their COVID vaccine or complete the series or even to go out and get boosted. We must do better. Next slide, please. So now I just want to spend a minute to talk a little bit about what else COVID has done to our health communities. What we found coming out of this pandemic is that people have not taken care of the conditions that they have. Those with hypertension or diabetes, those who have age-related issues, other preventive health care has gone to the wayside because of COVID. So what does that mean for our communities? We're seeing that the foregone routine healthcare is leading to worsening conditions for our patients. We also see more mental and behavioral health issues that have emerged after this pandemic. I don't know how many of you have participated in a telehealth encounter with one or more of your providers, but even with expanded telehealth access, it is not available to those who need it most because they lack devices or internet, and they don't have the tools that they need to have video calls with medical professionals. Now, as you look at this, the next graph, when it comes up, you'll see that on one side, the breakdown by ethnicity, and you see those numbers of people who did not get health care. The Black, almost 40% have not taken care of themselves. And then when you look on the right, we're looking at the federal poverty level. So poor people and brown and Black people again. And we talk about health equity. This is yet another sign that we have to look at who are we targeting to help and focusing our efforts on improving healthcare outcomes. Next slide, please. So those adults who have delayed or went without care and reported that the fact that they did not get their care affected their health, their ability to work, and their ability to perform other daily activities. The most common area that was skipped was dental care. And most of us know that if our teeth hurt and or if our feet hurt, you're having a bad day. So it's important that dental care be maintained because the mouth tells a lot about systemic illness. Then people said that they didn't go see their doctor or their specialist. And then finally, preventive health almost fell off the radar. People didn't go and do the things and the screenings, especially for cancers, as much as they should. So that downward line, what I wanted to use that to describe is life expectancy. So how does all of this relate? Well, in the United States, they've been tracking life expectancy for over 100 years. And it was 47 years in 1900. In 1950, the life expectancy was 68. And by 2019, it had risen to 79 years. But in 2020, it's the first time life expectancy in the United States fell, and it fell to 77. And it dropped a little further in 2021 to 76. Now, life expectancy for white Americans is 76 years, but for Black Americans, it's 70 years. And for women and men, there's also a distinguishing difference. Life expectancy is 79 for women and 73 for men. Very disturbing. In the last 2 years, what we've seen is that COVID-19 and drug overdoses are the biggest contributors to high mortality as well as impacting life expectancy. Now, life expectancy is only one measure of health. There are many others, such as infant mortality, maternal mortality, vaccination, cancer screenings, and how healthy someone has actually lived. So even when we take all of these things together, it's still very striking and very disappointing information. Next slide, please. So I want to end on a higher note and a bright note by saying there are things we can do and we can help our communities. So what are some simple things that we can do? Number one is we can all create talking points. We need to have a medical home. You need to know your family history. We need to know the things that we should reduce or moderate in our lives. And we need to make sure that we stay on top of our screenings. So we can help our community understand that. We can promote strongly the importance of having a primary care provider, someone that you trust, a health expert and a confidant. We can help communities understand and organize ways that they can coordinate screenings and address health issues and educate individuals. People trust people they know. So we, as leaders, can be those examples for our communities. Don't be tempted by internet and social media to address your health concerns because misinformation is real. We have to know when to seek help, and we need to know that that help is going to be available when we need it. Next slide, please. Pausing on long COVID, long COVID is real. And for those who may not have known, long COVID is now considered a disability under the ADA, or Americans with Disabilities Act. That happened in July of 2021. And it's important because there are people who did the vaccinations, they had COVID, and they still have some sequelae related to COVID. And we want them to know that there is help for them out there. And this may be one avenue for support for them. And the other thing I say is that I hope everyone has at least one COVID test in their cabinet at home. These COVID tests have proven to be very helpful because if you don't feel well, you can take a test and then you can follow up with your health professional. And we know that there were many free tests out there. I don't know, depending on where you are, where you may still have access to free tests, but if possible, we want everyone to have a test available to them so that they can test themselves and their family members. Next slide, please. I would be remiss if I did not put out a promotion for all of us research. We need people who look like us to be involved in research. We need to make sure that we are studying ourselves so that we can turn around and use that information to help ourselves. So the Recover program that is with the NIH is just one of the COVID studies out there, but there are other opportunities to participate in research. There are many chronic condition programs and all types of research. So if possible, we want to encourage our community to participate. And the next slide, because I want to leave some time for a few questions if we have any. So in summary, hopefully you've learned a little bit more about influenza, the signs and symptoms, and some prevention measures, as well as understanding things that you can do to mitigate passing on illness to others. Things that we can do as community leaders is to develop these talking points to help our community understand in words and ways that they can understand. We can coordinate vaccination sites in our community. We can help to build trust with health professionals. We can be examples and have the community see that we do what we say we do, right? We can partner with others. Some of you are aware of grant opportunities, working with other foundations, and helping to spend money that's out there to improve the determinants of health. Excuse me. And the CDC has several programs, one called Partnering for Vaccine Equity. And there are other vaccine programs that are not just for COVID, but for other conditions, including flu. And the CDC has already given $150 million in funding just for this flu season. We can build coalitions because all of these activities are all hands on deck. And whatever it is we do, whether it be community leaders, church leaders, educators, politicians, and others, and we can try to engage the press to help share messages on our behalf and promote healthy outcomes. So I'll pause there for our moderator to see if there are any particular questions that I might be able to answer. And I want to thank you all for your attention this evening.
Thank you so much. Thank you so much. I'm going to look in the comments and see if there's any questions. Miss Whitney, do you see any questions on your end?
Yes, I do. Thank you so much, Captain Buskey. That was an outstanding presentation, and we are so grateful to have you. Our first question is, why are Black people still so reluctant in receiving vaccinations? Is there any research around that area?
Okay, great question. I don't believe there's any formal research, but there are lots of polls and anecdotal analysis of information when we ask different target populations why they don't want to get vaccinated. A lot of mistrust. We're seeing an increasing anti-vax movement. People are using religion as a reason for not getting vaccinated. But just in Blacks alone, the Tuskegee experiment is still one you hear from. And even when people are told what the Tuskegee experiment was, it was not a vaccination experiment. It was an experiment where Black men were not treated for syphilis. It helps to help them change their mind when they understand. We hear about Henrietta Lacks and how her body was used in science, not in a way that people can appreciate. You know, they felt mistrust from medical professionals. So the first thing we have to do is build trust. I will say, just as an aside, there's not enough people that look like us in medicine. That's a challenge. And trying to help get our students educated so that they can be competitive and go into those medical professions and other ancillary professions, so that when you sit across the table and talk to someone about your health and medical problems, that they look like you. And that would help a lot as well.
Excellent answer, Captain Buskey. We have another question. How do Black people and people of color get involved in some of the research and testing and not experiments, but the trials, clinical trials, in order to increase our participation in those?
Okay, again, a great question. I'll say that when I was working in a particular practice, I sought out trials to enroll my patients. It is a little bit of work. It is a little time consuming. So where you actually can find that very easily is if you go to a large medical center type environment for your medical care. They often have lots of trials. Now, in the smaller, more rural areas, it may be that you have to do a little bit more work. And that's where we as leaders can help bridge that gap. And we can find on those websites where those trials are and help bring the trial to the community. Because again, it's going to be easier for someone that looks like me to sit there and explain to me what the trial is in terms that I understand, to make me feel comfortable. I will add that some of the trials pay a little bit of money. They may pay transportation to the doctor's office or even give them an honorarium, although that shouldn't be the primary motivation. But again, bridging the gap is something that we can do as leaders to help get our community signed up for some of those trials.
Thank you, and that is such an important issue, so thank you for explaining that. Our next question, you mentioned in your presentation that breast milk provides a certain amount of immunity when the mother is breastfeeding an infant child. The question is, what age should children get vaccinated with that in mind?
Great question. I can't say that I have memorized the pediatric schedule for vaccinations because there are many. And what they found is they start day one. First day after birth, they start with vaccinations. We can give things like hepatitis. We give other series of vaccinations based on the child's health and through months of their life. So usually when they come in for a well child visit, they're going to be vaccinated with something. And that can go on for several years, probably up until they're going to school. So that's where it starts. But again, having a good relationship with the pediatrician or other health professional related to the well child visits is where you start.
Thank you again, Captain Buskey. This is an interesting question. So there is a rumor or a report that the COVID vaccine impacts the heart condition of men between the ages of 25 to 50. Is there any truth to that?
Well, you started out with the question that, is this a rumor? It's likely a rumor. I have not heard of anything that specific about men and heart problems from a COVID vaccine. Now, COVID vaccines, like any other medication, can have some untoward effects, and we've admitted that from the very beginning. But I don't think I've heard anything as specific as that.
Thank you so much for that answer, Captain Buskey. There is another question. If you are traveling, is there a way to get the flu vaccine specific to the region that you're traveling to?
Great question. And that is why I made specific mention about the Northern Hemisphere. So being in the United States, you actually are in the best place to get your flu vaccine because it helps to cover for flu viruses in other countries. So getting it here, you're getting your money's worth. That's probably the simplest way to say it. But if you choose to get it like in South America or in some other country, you may not be as protected as you think you are.
North American vaccines are very effective. Thank you, Captain Buskey. Your next question, have researchers found a relationship between life expectancy and vaccination status?
Yes, there is a relationship. I can't say that I can quote it here for you tonight, but that was one of the factors that is looked at with life expectancy, living a healthy life. So people who live a healthy life and have vaccinations, exercise, keep their weight under moderation, minimize their tobacco use and alcohol use, all of those things together prove to show longevity. I don't think that you're going to find studies that are going to just take one of those factors. You know, when they look longitudinally, they look at the way people live, and they have lots of different things that they look at. So those are the common things that are in the studies that describe the factors for longevity. So vaccinations is one of those things that's on the list.
Thank you. Apologies. Thank you so much for that, Captain Buskey. We're going to do one more question. Looks like your chart showed that African Americans have a lower vaccination rate than other ethnic groups. How do we compare with regards to deaths and hospitalizations as a result of flu? I do believe you had a chart to answer that, but if you could expand on that, that would be great.
Yeah, so I didn't show the deaths and hospitalizations just in Blacks. I just showed it in general. But when you look at Blacks in general and you pull those statistics out, we don't do so well. Again, lots of reasons why. Sometimes it's delay in access to care, it's general access to care, it's fear, trust. By the time we get to care, we tend to be sicker already. There are just so many things. But again, trying to get ahead of it and help people prevent these issues is where we need to focus our efforts. And we've made some inroads. And in some communities, we do see upticks. But again, it's labor intensive work, and it's helping people understand in terms they understand. We're learning that when we use too much medical jargon, people don't keep up with us. So we have to make it in plain English, and we have to help and be patient, because that's another thing. We get impatient trying to help people who really want to try to understand and keep up with us. So when it comes to the deaths and hospitalizations, I don't have the figures drawn out separately for Blacks, but we do have poor outcomes in those areas.
That is such a great point, that sometimes the medical jargon feels inaccessible, and ways to sort of make that more accessible to the community. Thank you so much for that point, Captain Buskey. At this point, we are going to close out our question and answer session. I would like to thank everyone for participating with your thoughtful and interesting questions. I'm going to turn it back over to Ms. Shara Denton to close us out.
Hello, thank you again for joining our webinar today for the Influenza Town Hall. And I actually want to turn it over to my sister, Wilise Williams, who is the North Carolina State President for NCNW, and she will close us out for the evening. Thank you all for joining us, and thank you, Captain Buskey, for the remarkable presentation. I'm sorry about that. We're having some technical difficulties, so I will turn it over to our Executive Director, Janice Mathis.
Well, first of all, good evening and greetings, everyone. Captain Robin Hunter Buskey, your presentation was magnificent and exactly what we needed. It was orderly, concise, factual, and I did indeed learn something that I did not know tonight. So thank you so much for joining us. And I want to thank Ms. Rosalind Hannibal Booker for suggesting you to us. I don't know whether Ms. Hannibal Booker, our Director of Philanthropy, is on tonight or not, but she deserves kudos for helping us to find you, and we're very grateful and hope that you will join us again very soon for another one of these sessions. I also want to thank our crew, our technical folk, Whitney Guilford, and of course our Director of Communications, Mr. Johannes. Thank you for having this go off tonight without even a hitch. We appreciate that so much. And thanks to all 124 of you who attended tonight's session. That is a pretty good record of attendance, I think, for a subject as serious as this one is, and timely and important. I also want to thank Wilise Williams, who is president not of North Carolina NCNW, but South Carolina NCNW. Like me, she is a South Carolinian. She is also recently elected National Secretary of NCNW. So we want to acknowledge that. Shara Denton always does a great job. She is chair of our Health Equity Committee, and they do so much important work, not just on flu and COVID, but across the range of conditions that we're faced with: maternal health, breast cancer, emotional health. They are a hardworking group, and Shar deserves lots of credit for leading them. One of our guests was not able to get on tonight on stage, as we say in the webinar business. She joined us in the audience, and that is Queen DeGraffin Reed, who is president of NCNW. And so, Queen, we apologize to you for not getting you on with us. And the way these webinars work, you're not able to speak if you're not on the certain side, the stage side of the presentation. But we know how much work you do. We know that you are indeed yourself a community health worker and advocate, and have been really prominent in pushing these health equity goals in the state of North Carolina and across the country. I would urge all of you, if you have not considered NCNW, please, $50 a year, it's one hamburger a month. We can afford that. The information is good and timely, and there's no such thing as a bad question when you're in an NCNW event. We're all family here, and we welcome you. We generally have these presentations on the second and fourth Thursdays of each month around 7 p.m., sometimes 8 p.m. But we want to thank you for your participation tonight. Thank all of our guests and hosts. We are so delighted. I understand that Dr. A. Lois Keith, recently elected national chair of NCNW, is in the audience tonight. We certainly appreciate your service to NCNW, not just now, but over the years as co-chair of membership and vice president a number of times. We really appreciate you and looking forward to working even more closely with you in the days and weeks to come. With that, I will wish each and every one of you a good night and a blessed weekend, and we hope to see you very soon. Stay safe and stay well, because good health wins.